Good morning, good afternoon, and good evening, social marketers around the world. My name is Patrick Cook, and as president of the International Social Marketing Association, it's, as always, my privilege and pleasure to introduce you to the 31st in a series of webinars designed to advance social marketing teaching, practice, and research. Today, I'm joined by Susie Copperthorne, Dave Cutter, our technical host, Tamara Harbour, and Jay Cassier. Tamara helped organize today's webinar, and she'll be moderating, and Jay is the manager for our webinar series. We're going to begin in just a minute, but before we do, I'd like to share with you a couple of timely updates from the International Social Marketing Association. First, if you've been checking your emails recently, you know that we put out a call for nominees for our board of directors, and we were lucky enough to get 8 fabulous nominees. We are currently seeking your input and would like you to vote on these nominees. We're looking for 3 new board members. You can vote at isocialmarketing.org, our website, and voting is open until June 6th. Also want to remind you of the upcoming conferences organized by the member associations of the International Social Marketing Association. So the Australia Association of Social Marketing is having their conference in Singapore, July 15th and 16th of this year. The European Social Marketing Association is having their event in Antwerp on September 6th and 7th. And our newest member association, the Africa Social Marketing Association, is having their conference in Uganda on 13th and 14th of September. So without further ado, I'd like to turn it over to Jay.
Thanks, Patrick, and welcome everyone. I want to remind you, if there is more than one of you at your location, we would appreciate it if you'd let us know how many you are using the chat box. That's the only way we know. Also, please ask your questions using the chat text box as they come to you. Don't wait till the end of the talk. We'll answer your questions at the end in roughly the same order as they've come in during the webinar. I've got 2 polls for you. The first one here, how you heard about the webinar. If you don't mind filling that out, please. So we're starting to see people filling it out and returning it. Thank you. I'd like to get a few more. I guess a lot of responses is my email. It's the most common way. Some people found it from the website, so that's good to know as well. Thank you. And then our other poll is where you're located today, please. And so far, everyone's in North America. Is that right? Is there anyone who's not from North America? Other than speakers, of course, and our technical host and so on. Okay, fair enough. So with that, I'd like to turn it over to Tamara, who's going to introduce our speaker today. Oops. Sorry, Tamara, we're both doing it together.
That's all right, teamwork, right? Thank you very much, Jay, and I'm very happy today to introduce Radica Howard as the featured presenter for today's webinar. Radica is based in London, England, where she is a cultural insight specialist and a behavior change consultant. She arrived in England from India in 1998 after completing her postgraduate degree in dietetics and public health from Delhi University. She is fluent in several South Asian languages, Bengali, Urdu, and Hindi. Radhika is a subject matter expert in the area of culture and its impact on health and health-seeking behaviors. She has worked on a number of projects designed to gain consumer insight and to develop behavior change communications on public health issues such as cancer, diabetes, and dementia, especially for Black and minority ethnic communities. She specializes in bringing the voices of excluded and vulnerable communities into the process of policymaking and communications planning and has considerable experience working with hard-to-reach and marginalized communities. Currently, she is working as a consultant with England's National Health Service for the West London Clinical Commissioning Group, and she is acting as an Inclusion and Equalities Advisor for the North Kensington Grenfell Recovery Program. This program was put in place to help residents recover from the major fire in June 2017 at the 24-story Grenfell Tower, which a lot of you will probably remember because that fire made international headlines, and the recovery is ongoing. Today, Radhika will be sharing her insights on delivering healthcare in culturally competent ways. Radhika, I know we're all looking forward to hearing your insights on this topic, as cultural competence is extremely relevant in our increasingly diverse world. So, welcome, and let's get started. Over to you, Radhika.
Thank you, Tamara. Hello, everyone. Today, I would like to start a conversation with you about culture and health. I'd like to look at some terms that we use in this context in social marketing, such as cultural relevance and cultural competence and what that means. Also look at the role of culture and our cultural beliefs in how we receive and interpret health messages. So the whole area of communicating health messages to different cultures. And look at some culturally relevant approaches. So I'm going to share with you examples from my research and other works that I've done with the communities. I think before I start, I'd just like to emphasize that, when I'm sharing my examples and the slides, it's not about generalizing and creating stereotypes. I don't want us to make any assumptions. There are differences and variations in cultures, within subcultures, in families. So it's all about recognizing the difference every time we have a conversation. So the first thing is I just want to set the scene and explain some terms that I'll be using throughout the presentation. So we talk about diversity. And by diversity I mean the inclusion of different types of people from different cultures, from different races and ethnicity. When I'm talking of diverse communities, this is what I mean. And then cultures. So again, by culture, it's looking at groups, people coming together from different religions, different beliefs, languages, social habits, etc. So when I'm talking of multicultures, it's looking at different communities and cultures living in the UK. And finally, Black and Minority Ethnic, or BME. This is something I'll be referring to throughout. And this is the terminology normally used in the UK to describe people of non-white descent. So I will start by sharing some statistics, some facts and figures about diversity in Britain. 1 in 6 people living in the UK are from an ethnic minority. And when it comes to London, 41% of Londoners are from BME backgrounds as compared to 10% in the rest of England. So London is very diverse and very multicultural. And then when we look at some other figures, so in 8 of the London boroughs, the BME school population is greater than 80%. So we are talking of a majority minority. And there are 32 London boroughs, so there is quite a high diverse population in London. And the prediction is that by 2050, up to 30% of UK population will be from minority ethnic communities. So I think the key points I'd like to make here is that diversity and cultures are here to stay. They will be growing. Diversity also means diverse and different needs and different behaviors. So when we are working in such environment, then this one-size-fits-all approach might not work. Looking at diversity in Europe, there is growing diversity in Europe, and the trend shows that the BME population will grow, and this is because of migration, cross-border movements, and more recently, Germany and Sweden have accepted large number of refugees. So the trend is that the BME population will rise due to migration and higher fertility rates. So, and I'm just sharing it that this is not just a UK concept, this is happening elsewhere also. So why does culture matter in social marketing health programs? I believe health is a cultural concept because culture frames and shapes how we perceive the world. So in UK, like I've said, the BME communities is a growing population and set to increase. And this has implications on health services, and how we provide services to BME communities. So, for example, the likelihood of developing type 2 diabetes is 6 times higher in South Asians than in Europeans. And by South Asians, I mean the Bangladeshi, Asian, and the Pakistani communities in UK. The South Asian people make just 4% of the total UK population, but account for an estimated 8% of all diagnosed cases of diabetes. So this just shows that we really need to understand behaviors and what are driving these to be able to create the right intervention, the right health messages for prevention. Some more figures. According to Black Mental Health UK, people of African and Caribbean descent are 50% more likely to be referred to mental health services via the police than their white counterparts. And when I read things like this, I often wonder why this is happening. So there are inequalities, and there have been recent reports that suggest that the health inequalities are also on the increase. So these inequalities cost the NHS, that's the National Health Service, dearly. And they put a lot of pressure on acute, that's hospitals, primary care, mental, and other health and social care resources. So why culture matters? Because we have to provide BME communities with the right health and social care that will save the NHS, the National Health Service, money, but also reduce health inequalities. And I think it's really important to understand the behaviors, to understand the cultures of the patients, families, and communities, to be able to provide services that are culturally relevant, culturally accessible, and culturally compliant. So it's about changing behaviors and improving health outcomes. I just want to look at some terminology we use here in the context of health and social marketing. We use the word cultural sensitive services. We talk about cultural relevance and also cultural competence. I want to look at these terms in a bit of depth to see what this means and how this affects or changes behavior. So when we talk of cultural relevance is the ability to interact effectively with people from different, diverse backgrounds. So it's the ability of having the skills and knowledge to recognize diversity, to recognize cultural differences. It's the skills, ability, and knowledge to reflect, to understand what these means, what are the needs. So it's understanding the needs, and then respond to this by taking the right action, by developing appropriate interventions. Some also call this also use the term cultural intelligence instead of cultural relevance. At an organizational level, this cultural relevant organization is all about being aware of your strengths and weaknesses of your workforce. And then we talk about cultural competence. So there are several models to explain how we develop cultural competence. I see it as a process that consists of different stages. So the stage one, the start of the journey to achieve cultural competence would be to have cultural awareness. And cultural awareness is all about accepting a difference and understanding that there is difference. So to give an example, if you are planning a service, to be culturally aware would mean that you recognize that there is a diversity and profile of service users, that you will do some to understand the demographics, to understand the ethnicity and breakdown of your service users. Cultural knowledge is to then take steps to understand their needs. So what do we need to do to reach out and provide suitable services to this varied and diverse service user base that I have? So for example, if you feel there is a high number of Muslim population, then you will, and if you're providing a hospital service, then it would be looking at halal meals or providing a prayer room. These are some of the examples that I'm sharing. The next stage in the process is being culturally sensitive. This is understanding the behaviors and taking the right steps to take your services closer to your service user, closer to the community. However, what I find is that being culturally sensitive, it is moving in the right direction. But in social marketing, in behavior change, being culturally sensitive doesn't necessarily change behaviors. So for example, if you're providing, say, screening services and you want to encourage people from BME communities to take up screening, you you've been culturally aware, you've identified that, yes, you've got, say, the Bangladeshi or the Somali communities. You know that you need to take the services in the community, so you provide the service in the community. And then by being culturally sensitive, you translate the leaflets. But that doesn't necessarily mean that it will encourage people to start taking up the screening services because there'll be a lot of issues. That's where cultural competence comes into play. Cultural competence is the ability to function effectively. It is having the capacity to provide care that meets the patient's social, cultural, linguistic needs. It's embedded in the organization. It's consistent. And by being culturally competent, we will be able to provide culturally responsive service. So in the NHS world, it's all about providing patient-centered care. It's all about changing behaviors and improving health outcomes for the patient. I will now share some examples. We look at how culture shapes behavior. So I often refer to the iceberg model because culture is like an iceberg because there is so much that goes undetected. We only see the visible. And we tend to respond to what we see. So we see somebody's dress, we hear somebody's language, we look at their appearance and their habits. And the culturally sensitive aspect of the stage that I was talking about in the earlier side is how we respond to the visible bits of culture and behaviors. What we don't see is the drivers of culture and look at what is actually driving the behavior. So it's the person's belief, it's the norms, it's their value systems, it's their perceptions, etc. These are the drivers of behaviors. So to understand the visible, we need to understand the drivers of these behaviors. And to be culturally competent is actually doing that, is looking at below the surface of the water to see what gain the insights to understand behaviors. I'm now going to share some examples just to make this point a bit clear, and this is all from the research and community work that I have done. One of the areas of work that I'm doing is with hospitals to look at how we can reduce families and people using the accident and emergency services for minor conditions. And one of the cohort of patients that were using A&E for minor conditions were and a lot of B&E parents and families. And when I looked into this further, the doctors would typically say that some parents insist on antibiotics for minor cold and cough. So this is what they were saying. When you spoke to the parent would say, my child has fever and cough for a week. I went to my GP a few times. He gave me call. I asked for antibiotics. He said it wasn't necessary. I wasn't convinced. I went to the A&E. I asked for antibiotics. I saw a doctor after a long wait, but even the hospital doctor said the same thing. They didn't do X-ray. They didn't give me antibiotics. This made me think that they don't care and the quality of the service is bad. Now, what we have to say and what we have to recognize is that a lot of immigrant families are coming from countries like India, Pakistan, and Bangladesh, where we get antibiotics over the counter. In UK, you get it on a prescription-only basis. So the perception is, or an expectation from the services, that antibiotics means good quality care because that's how the cultural conditioning is. So when that doesn't happen, the parent or the patient then starts judging the services from their cultural standpoint. Another example is to do with smoking. I've done a lot of work to look at how we can encourage people to give up smoking and with BME communities. And a classic example I see is where the GP is telling the patient, you need to stop smoking. And the response from the patient, and this is a quote from a Bangladeshi old man who's in his 70s, saying, I've been smoking for the last 30 years. My GP tells me to stop smoking. What's the point in stopping now? I'm 72 years old and I've had no problem so far. If Allah wants me to live, I will. Now, many, many cultures believe that life events are predetermined. So that's the fatalistic attitude. So if it's God's will, it will happen. So what this mindset means is that people then don't take responsibility and kind of resign and accept what is happening. So for Hindus, it could be the karma, and kind of this fatalistic attitude influences our health behaviors. Another example is linked with our learning styles. Different cultures have different perceptions and different learning styles. And I have done a lot of work around self-management. So in the UK, we do work to encourage patients to become more self-reliant and self-manage for long-term conditions like diabetes or COPD. And we have some structured programs where we tell patients how to kind of look after themselves. And one of the common problems, and what I hear from practitioners, is that it's very, very difficult to engage people from BME communities. It's very difficult to get somebody from communities to attend the self-management workshop. This is what they see. So when we got some people, and I worked closely with them, we got them in the sessions, the feedback I got from them, and this is the comment, a quote from a Somali male who's 75, who attended a 2-hour COPD workshop, said, "Is there an easier way to do self-management? Can I not take a tablet instead?" And from a diabetes workshop, another gentleman said, "I don't have the time to do all this self-management. You can explain this to my wife and she will take care of things." So this whole concept of self-management and self-care does not work. People also are not used to this very structured education, and it's different for different cultures. So, and I think that is how then it affects how they respond to services. Another example is, again, I've done work with BME mothers in maternity services, in weaning, and in other areas of early child health, where the health messages or the professionals are telling parents giving one set of instructions and health messages, and the parents are not really following it because there is a clash with their cultural beliefs and their tradition. So, for example, the midwife is telling the mom, "You should make the baby sleep in a separate cot because this is what we do in this country," etc., etc. But the mom's reaction is, "In my culture, the baby sleeps with the mother. I could never put my baby to sleep in a separate cot. No one has done it in my family. It sounds so cold. This must be part of the English culture. But in our culture, we believe that the baby gets the warmth by being close to the mother." Now, the health professional is doing their job. They are correct. And so is the mother. It's not about a clash in cultures, but it's about recognizing the behavior and the cultural mindset of people so that we can make all the health messages culturally compliant and culturally accessible. Another related pattern of behavior we see is really, again, to do with health visitors, to do with early weaning and giving babies food. They're saying many Asian moms don't follow the feeding guidelines. And when you talk to the mothers, they say, "In my family, it's my mother-in-law who is the head of the family. She's experienced and has brought up children. She says it's okay to start giving mashed food to babies from 3 months. Otherwise, the child will go hungry. I put rusk, which is a light biscuit, in the bottle and give it to my baby." So again, when we are working in diverse settings with BME families, as professionals, I think it's really recognizing who's making decisions, what are the beliefs, what are the traditions, and then present the messages in those contexts so that it's accepted by the wider family, not just by the mom. So it's really understanding cultures to encourage the families to adopt the behavior. Now we talk about the me versus we. So culture is commonly divided in 2 broad categories, and these are 2 ends of the spectrum. The me, which is the individualistic culture, versus the we, which is the more collectivist culture. So it's the person-centered versus family-centered approach. And here I'd like to share my own personal example of the me versus me. So I'm from India. I've been living in UK for a long time. My husband's half Spanish, half German. Now, 20-odd years back, when we first came here, we went out for a meal and ordered food. Now, in India, we all sit together and share our food. So we have 3-4 dishes which we share. We ordered a couple of dishes, and when the food came, I started helping myself. And my husband took one dish and put it on his plate, and he said, no, we don't share. This is mine, and that is yours. So I said, no, but we share. In my culture, we share. And he said, no, in my culture, we just have one portion, and we don't share. And I think so I was quite puzzled, but I think for me that was the beginning of understanding that clear, the different, the me versus we, there are differences in values and beliefs and how we see things. I'm not judging about which one is right, but it's about recognizing these differences. So let's look a bit about the traits, the me traits. So what does this me trait, what are the different traits? So it's looking, the individual's rights take center stage. Personal independence is valued. It's all about my rights. Being dependent upon others is often considered shameful, so I want to do it myself. Freedom, high levels of competition. People tend to be self-reliant. In contrast, the we traits is all about interdependence, harmony, family security. Families and communities have a central role. They're more likely to turn to family and friends for support during difficult times. So typically health decisions are made by the family. Social rules promote on selflessness, putting the community first. Working as a group is supported. So you can already see that there are clear differences in the way we think and in the way we behave if you're from the me versus the we culture. So what does this mean in the health context? What I've found is that approaches to healthcare are influenced by these tendencies. So how we receive messages, how we interpret messages, all depend on where we are on that spectrum. As a provider, if you're a provider from the mainstream in the UK, which is the me culture, you tend to be responding to what is visible, which is what you see on the tip of the iceberg, and also from the very me perspective. So you can see that there is a chance of mismatch. So responses to health promotion messages tend to be shaped by cultural orientation. So in the individualistic cultures, stress the importance of each person taking care of him or herself without depending on others for assistance. So this whole concept of self-care, self-management, goal setting is very key to the me culture. So cultures in North America and Western Europe tend to be individualistic. On the other hand, in collectivist cultures may instead stress sharing the burden of care for the group as a whole. That's where we look at families involved in health decisions. The role of community becomes very important. So it's more about community goals rather than the individual goals. So cultures in China, Korea, Japan, South Asia, and South America and Africa tend to be collectivistic cultures. So in terms of health behaviors of collectivist cultures, what we typically see is there's deference to authorities. People from BME cultures will accept what the doctors say. They will not question, we will not challenge, because we believe that the doctor knows best and he will do what is right for me. Family values are key, and everything is seen from a very collective lens. There is this whole emphasis on respecting elders. It's our duty, it's our tradition. And that's why, when I shared that example of the daughter-in-law, she will do what the head of the family would say, whether it's the mother or the mother-in-law. And you can't be going against it. Again, I don't want to be generalizing and creating stereotypes, but this is what tends to happen. Health-related decision-making and problem-solving are typically done as a family unit. And health messages coming from a me perspective may not always be effective. Right. I'm going to talk a bit about mental health, looking at cultures, behaviors. Now, I worked with Asian elderly people for a number of years and done a lot of work around dementia. And this is an example where I was supporting and working very closely with a Pakistani elderly woman who was being assessed for Alzheimer's memory test. And this is some time back where they used a test called the CAPE test, which is the Clifton Assessment Procedure for Elderly, where you ask a number of questions to assess one's memory. So there were a list of 10 questions, and the clinician then asked the question. The first question was, so what are the colors on the Union Jack? Who's the Prime Minister of UK, etc., etc. Now, this lady knew a bit of English, so she could understand what was being asked, but obviously she couldn't respond because it wasn't in her cultural context, so she scored very low. So at the end of it, I asked the clinician if he would consider just modifying some of the questions, and suggested that instead of asking this lady about the colors in the Union Jack, ask about the colors on the Pakistani flag, again make it more relevant to her culture. So he did that, and her score was completely different. So I think this just made me think, is there a cultural bias in the assessment tests and diagnosis of some BME older people? And I really want us to think and consider this. Do we need to do something differently? Is this an issue when we are working with Western systems and Western tools with BME cultures? Again, I would like to share a bit more about culturally appropriate care in the context of dementia with Black and minority elders. So the current generation of minority ethnic elders in the UK are people who migrated here in the 50s and 60s. Many have come from rural or provincial districts and are unable to read or write. So low levels of literacy, low levels of fluency in English. And many of them haven't had formal education. So they are less, so the education they've had is less related to the tasks involved in cognitive tests here. Now, the tools and test items being used here require numeracy or literacy, either in English or in the first language, and therefore may disadvantage a lot of the BME older people we are talking about. So dementia tests rely heavily on linguistic factors. So whether you're doing a mood assessment or a mental state evaluation or a cognitive examination, there you need a certain level of language ability to do that. The other issue is the language used in mental health. When you're talking about how do you describe your symptoms and how you're feeling, it's very different in terms of how you express it and also from a clinician point of view, interpreting it. It's more than just a literal translation word by word. So even if you're using interpreter, I just want you to think about how this might work. So for example, if you're asking a person to explain how they feel, and if they're really feeling low and depressed, she might say, and this is in a Punjabi Urdu word sentence here, which says, Dil dukda hai, which means my heart is hurting. I'm feeling so down. My heart is hurting. Now an interpreter might translate this as I'm having chest pain because heart is chest. So the literal translation is my heart is hurting. And if the clinician then doesn't look at the cultural context or doesn't understand these cultural issues, might interpret as a chest pain. So just to give an example of how the language is different. So dementia, again, different cultures express mood and memory problems in different ways. There is no language in certain, or no words in certain languages to actually talk about that explains what dementia is. Some cultures will somatize, that my head hurts, to express sadness or memory problems. Behavior perceived as challenging in one culture and not others. And abnormal experiences perceived as pathological in one culture and wisdom in others. So, there could be a lot of mismatch in diagnosis and interpretation. I'm going to talk now about culture and communication. Culture not only shapes thinking, it also defines how we communicate and how we actually receive and respond to messages. So I was involved in a project for the government here. It was Change for Life, where we were developing health messages and concepts for a campaign to promote healthy eating and lifestyle for parents with little children. And one of the concepts or the concepts we were testing for the campaign was full of beans. So we actually showed parents who could speak a little bit of English, who understood English, different ads, and this was full of beans, and asked them what they understood when they saw this, what was their interpretation. Now, a lot of the mothers who saw this interpreted as that they were being encouraged to give beans to the children. They didn't really understand the concept because certain you cannot translate certain phrases in different languages. It just doesn't work. So even though the mothers understood English, their comprehension here was an issue. So when we are communicating in different cultures, the images, the language used is really very important, because there is a chance that it's not going to be interpreted as the way it's intended to be. And what I have found is that in different cultures, people don't understand risk. And then you have the language. So when you are saying things like be clear on cancer, the call to action is not understood. And this one on the right is an image from a Stop Smoking campaign. So when we showed it to BME men who were smokers, the target audience, they didn't really know what was happening. They didn't engage and didn't really recognize what the call to action was. So culture defines modes of communication. I think it's not just about knowing English. It's about the comprehension and interpretation of health messages. Not all languages have words for something that exists in other languages. For example, in English, you have lots of different types and words to explain pain, but you don't have that in other cultures. Tone of the message can make or break the relationship. For example, humor does not work in some cultures, in Somali culture. So again, I'll give you an example of a mom. They tend to have large families. She was having a third child in the hospital. She was being discharged, and somebody in the ward, or one of the staff, said, "See you next year." That was a very friendly comment, not intended to be offensive. But that humor, or the way it was said, was interpreted as the Somali mom as being that they are being racist. So I think there is this difference in the tone, and that can be interpreted differently in different cultures. The context for communication may also affect the meaning of translated and interpreted words. The intended meaning may be lost and can cause confusion. So for things, there's a big campaign here for Change for Life, around 5 a day. But what I think a lot of BME, if it's not very clear, a lot of BME families struggle to implement health messages in their cultural context. Therefore, we need to look at how we can make health messages more culturally relevant. The other key issue, again, as I found it is not just about the families and the individuals and the patients, but it's also about how professionals interpret messages. So whether you're doing research or gathering insights for behavior change, I think understanding the cultural context is very important. And again, I was doing some work with young people around race and identity. They were second generation born in this country, and we asked them to do some activities with collage, etc. So the Bangladeshi group of young people made a flag, which is on the left-hand side. There was a senior researcher who was working in the team, came to the table and said, "Oh, you're drawing traffic lights." So completely didn't understand the cultural context and misinterpreted what was happening. So what is culturally accessible communication? So I'm just going to share some examples of what works in certain cultural communication. So messages need to be visual. They need to be simple, direct, to the point. Less text, more visual. Call to action is very, very clear. Again, targeted. When we talk of targeted campaign, I think we need to be looking at the me versus we. We need to be targeting the individual, targeting the family, targeting the community. We have to be looking at reducing the taboo and encouraging the family to be involved in having the conversation. And then this is another example of how, when we actually don't spend time thinking about it at the outset, at the start of a project, how things can go wrong. I was asked to evaluate a project for South Asian families in the north of the country who were at risk of heart diseases. There was a course set up for them to teach them healthy cooking based on the principles of a Mediterranean diet. The moment I saw the brief, I knew what had gone wrong, and I could have actually done the report without even talking to the families, because the whole concept and the way it was set up was not right. You are encouraging, or you're expecting families who cook a one-dish meal, so they cook a handi, that's a pot on the right, to completely adopt a different cultural diet. So when I spoke to the mothers, they said, this is not going to work for us. First of all, we don't use olive oil. We cook for 7 to 8 people at the same time. They were targeting the men. They were teaching men how to cook, but it is the women who do the cooking. So, I mean, this is a case study that I often share. And I think the key point I want to make here is that we need to start thinking about it at the outset when we're actually planning the work rather than afterwards. And finally, this is my the final example. I love this slide because this is such a simple approach that has worked so well in Zimbabwe to deal with the mental health problems that were happening. There was a rise in mental health, and they didn't have enough funds to have counseling services. So they came up with this idea of the friendship bench. It was a culturally relevant approach to mental health care. And, mental health is a taboo subject. Nobody speaks about it. But traditionally, it was the older women, the grandmothers, who played the role of the counselor in the community for younger members of the family. And they tried to recreate this. So it was a model that was adopted. So they had the older members in the community trained to talk to the youngers and others in the community on this friendship bench. Initially, it was called the mental health bench, so nobody came. Then they rephrased it, they changed the name, and it was called the friendship bench. This made it more acceptable for the community, and it really worked, and people started engaging with the idea and having conversations. They're actually evaluating this model to see whether it can be a blueprint for mental health care in developing countries. So finally, I think just to kind of summarize, I would like to say that if you're talking of culture and behavior, we need to look at change people's actual behavior, and in order to do that, we need to gain cultural insights. We need to step into their world to understand their lives. We need to look at behaviors in the wider cultural context. Look beyond the tip of the iceberg. Needs to be, we need to think about family-centered and community-based approaches. These work well and are more effective with BNE communities because we are talking about the we culture and not the me culture. Community-based approaches make it socially acceptable, becomes social norm. We need to be thinking of community goals, more family goals. Messages need to be culturally compliant. The tone and content needs to be culturally relevant for the audience. So when we are communicating, we need to be thinking about how do we communicate for change and not just to provide information. So I'm going to finish here. Thank you.
And thank you, Radhika, very much for a very insightful presentation. I think we all learned a lot from that. Your examples were very compelling. I think you've made a great case for the need to have cultural competence reflected in social marketing messages. And we do have time for some questions and answers. So let us start with a question that Kathleen Horton had. And I think this question came in when you were talking about the cultural differences where in maybe North America and Europe, the baby sleeps in a separate cot instead of with the mother, but in other cultures, the baby sleeps with the mother. And so Kathleen's question is, then how do you give advice that conflicts with cultural tradition?
So I think it is, so we are talking of first understanding the family context, then looking at the cultural context of the family, and again giving a rational explanation to see how it fits into the world. Because what I found in my work is that, when we are trying to explain things or give health messages, people need to have a buy-in and understand the value of it. And once they understand the value and how it's going to help them and the family, then they're more open to receiving the messages. We are coming, so again in the UK, we're coming with different mindsets, with different beliefs. But at the same time, it's about learning the system. So there has to be a change in our learning also. And that can happen with an open and honest dialogue and discussion. Often that doesn't happen. You give the advice, and if it's not being taken up, then nothing is being done. I think what needs to happen is just to understand the context and present it in a way that will encourage a Q&A and understanding from both sides. and then also look at who else is there in the family who can be involved in that conversation, because the decision will be taken by the family rather than the individual.
Thank you. It raises a question for me, though, when there are cultural differences like that, how does one, to follow up with Kathleen's question, how does one offer advice that conflicts with cultural tradition without making it come across that one culture is right and one culture is wrong? So is that to say that the mother that allows the child to sleep with her is somehow wrong when that's been a tradition that's been going on?
And I think that's what tends to happen, because where it has happened and when I've spoken to mothers, I think it's how it's been approached and presented, where a lot of BME mothers have felt very judged. And I think that's where the problem is that initial engagement, connection, conversation, and building trust. And that's cross-cultural. It's not just with BME mothers. It could be with anybody. And I think it's about how we engage and approach and how it's actually presented. And sometimes the way it's been presented, I think people do feel judged. So I think we have to be mindful, and it's also a very sensitive issue. So it's what I can say, it's not about creating a conflict, and it's not about saying the me versus we and these are different, but it's about finding a way of making what the message culturally acceptable. So if it doesn't happen in the culture, it's about understanding why, and then explaining the rationale of why we are doing it, and leaving it there, because people need some time to think about it, check with others, and then make up their mind.
Right, so initiating
Does it answer your question?
I
think we just need to talk. There is no simple solution.
Right. Yes, I can see that. And it sounds like it's about initiating that conversation and that dialogue so that there's more understanding, and then just planting that seed and then seeing where it goes. Because if they feel open and comfortable to discuss, then you have that relationship to build on. Okay, and Kathleen, you let us know, please, in the chat box if that answers your question or if you have a follow-up to that. Another question came in from Gary, and I apologize if I'm mispronouncing it, Wooten. He said, I once led a lung cancer prevention social marketing campaign, and we came across the dilemma with competing ideas on what the next step should be. When white and BME groups liked and engaged with very different campaign concepts, messengers, and propositions. Do you have a view on how a campaign can or should be delivered in the same town or area at the same time, but with different messages?
Oof. How long do I have to answer this?
We've got about 5 minutes.
Do you have a...
Seriously,
yes,
we have about 5
because
minutes.
I have worked... I'll try. I have worked on a similar campaign, social marketing campaign on cancer. And it has to be, we have to prioritize. So again, the first thing would be look at who we are targeting, right? Again, so this is what I did. So when we did this, we were targeting the South Asians. We did a bit of insight work to understand their behaviors, their attitudes to health, look at who the decision makers were in the family, look at what media they were consuming. So we did a really detailed insight gathering for the South Asians around, how they respond, what works and what doesn't work. And then we came up with a set of health messages addressing all the issues that I've talked about, removing the fear of cancer, involving the families, making it positive, and very direct messaging. And the tone of the message was very different. So, if you look at the start, it's doing the insight, deciding who we target, and then understanding the audience better and what medias they consume, then come up with the message testing, and then looking at using, translations or engaging with the ethnic media. So it's the message and how it's communicated. So it's also looking at messengers. So do we then get faith groups involved in conveying certain messages around cancer? So it's looking at what are the different options out there to also convey the message. And then, so that's a kind of an overview as to how I would approach it.
So I'm wondering, does that mean you would have two parallel campaigns going on? The example I was thinking of is if you have a BME diabetic target audience, but then some non-BME diabetics, would you have two different messages or campaigns going out to each audience separately?
Yes.
Okay.
And this is what
them.
You can't try and combine. So, for example, when I was working in the UK, there was a big campaign on. It was called the Cancer Chancer in the north of the country, in North England, and it was a massive campaign to raise awareness of cancer. But what they found is that the South Asian communities just didn't engage, and this is in part of England with a very large population of South Asian population, also affected by cancer, where they were presenting very late. So they really wanted to engage, but it failed because again the communication messages just didn't work. If you look at the images, if you look at the language, the tone, the humor that was being used, it just didn't work. So we did this research, and they came up with a parallel campaign, a targeted campaign, using very different languages. It was in English, but very simple, direct messages with different images targeting the South Asians. And then they evaluated it a year later, and it showed that it had a better reach and it engaged more than the mainstream campaign.
Very interesting. So that is a study that shows that cultural competence in a social marketing program actually produced better results.
And just one more, I'd just like to add something, Tamara. The slide that I showed about the food, Mediterranean diet versus healthy handi. If you are looking to change behaviors, encourage behaviors or modify behaviors around healthy eating lifestyle, it has to be within the cultural context. There is no point suggesting somebody a completely different cultural regime, whether it's food or exercise, if that community is not used to it. We encourage people to go to the gym, but if women don't want to go to the gym or are not used to it, it's not going to work. You can't expect people to start suddenly having broccoli and olive oil if they're used to very different kinds of foods.
So what
it has to be targeted. It has to be relevant.
So what I'm hearing is that the cultural differences override any similarities in terms of what you're trying to promote. So if you're looking at diabetics, they're not. You don't send out the same message to all diabetics. If there's cultural differences, the cultural differences come first before the fact that they all have a similar health condition. Is that fair to say?
And it's being mindful of how they will respond, and then take that into account at every stage of their treatment care.
Right. So I think we can maybe get in one more quick question, and I think, where do we begin? So if someone is aware that in their workplace or they're preparing a social marketing campaign, that there is a lack of cultural competence, how does the process of acquiring cultural competence work? Are there particular strategies or approaches for gaining cultural insights and acquiring cultural competence?
So I would refer to that slide where I talked about the process with the different stages. But I think the first stage is recognizing that there is a diversity, there are differences, and that we need to look things from a different perspective. I think and that acknowledgement and that commitment has to come from the top. Often I see it's the front line or people who are on the front of delivering services are kind of given the task of doing the right thing. But I think it's the thinking at the start of the process. So it's like, let's acknowledge that we need to do something differently and let's commit to do it. And then it's about, the stages in marketing. So you get the insights, you understand what works, doesn't work, who's the decision maker. But then it's also creating a culturally competent workforce. We are working in very diverse communities now. So it's really, it's this cultural competence training, skilling up the workforce in recognizing these differences and responding to it. So it's not a tick box. I think it's a process, and we need to just start with making that commitment and then building on it. And it comes with experience and with training, and we shouldn't be afraid of asking questions because, I haven't learned it. I'm constantly learning, but I go with an open mind, and I know that this is not going to work. So it's about understanding about what is happening and why is it happening, and then how do we connect with that community in a way that works for both of us.
Well, I can certainly say that today you have done that for us. You have given us that acknowledgement that there is a lot of cultural diversity and a lot of factors to consider within the cultural diversity, and you have certainly provided us with a lot of awareness today about what it takes to be culturally competent and how important that is to get the results we want from social marketing campaigns. So thank you for that. Again, you've made a compelling case for why culture matters, and I'm sure all their listeners today have gotten an awful lot out of that and will be looking at their social marketing campaigns differently going forward. And Julie Heinz has offered a comment that this was a wonderful presentation and very informative, and that incorporating people from the community and solutions informs cultural competency and reduces the chances of paternalistic approaches, which is a really good point. So thank you again very, very much, and I will pass this on now to Jay.
Thank you, Tamara, and thanks to all of the participants in today's webinar. I'd like to remind you that as you're leaving the webinar, we'd like to get your impressions of how things went. Even if you've been to other webinars before, we depend on your answers as we figure out how we're doing and what to do next. Also, here we go, upcoming events. You can find these on our website as well. We have a calendar, of course, of many upcoming events. These are just some from the calendar, including the social marketing conference at the University of South Florida in Clearwater Beach, June 27th to 30th. For those of you in the area, hope to see you there. I'll be there. And also, we will have our next webinar in August. It will be August the 15th/16th. The title is still being determined, so we'll get you those details as soon as we have them. And finally, I'm going to put in my own thank you to our speaker. This is the second of her webinars, and thank you so much for doing them with us. And finally, thanks to Susie Coppathorne and Dave Cutter for handling the technical aspects of today's webinar, and to Tamara Harbour for helping organize, and to Patrick Cook, ISMA's second president. Patrick, over to you.
Great. Thanks very much, Jay, and thanks, Tamara. Both you and Jay make it a real pleasure and make it seem real easy. I also really wanted to call out Dave Cutter for taking on the new role of technical host, and a special thank you to Susie Coppathorne, who has been our technical host for these webinars over the last almost year and a half, and will be leaving us in this role, but continuing to stay with us in the association. And finally, Radhika, I really wanted to thank you again for an excellent presentation. It was very interesting and very helpful, I think, for all of our practice. Also wanted to do a final thank you to the participants who took the time out of their day to join us. We appreciate your continued support and participation, and we hope to see you at the next webinar coming up in August, as Jay mentioned. So until then, don't forget to keep visiting the website, share your events on the calendar, and don't forget to vote. The voting is open through June 6th for our new board of directors. So thanks again. This is the International Social Marketing Association, and we now conclude today's webinar.